According to the World Health Organization Global Tuberculosis Report 2025, Nigeria ranked 6th globally and 1st in Africa among TB high-burden countries, with an estimated 510,000 new TB cases and an incidence of about 219 per 100,000 population, accounting for roughly 5% of the global TB burden. TB remains a major cause of mortality in the country, with an estimated 61,800 deaths annually, including among people living with HIV. Men are disproportionately affected, contributing the majority of TB cases and deaths, yet they often face barriers to timely diagnosis and treatment due to work-related constraints, service delivery approaches that do not align with their lives, and the prevailing social norms, which widen the detection gap. This is evident as only about 402,000 cases were notified, highlighting the urgent need for gender-responsive, men-focused strategies to improve early detection, treatment access, and survival outcomes in Nigeria.
Nigeria is the most populous country in the continent of Africa. Nigeria faces challenges with tuberculosis surveillance. First is the issue of a large volume of people with the disease who have not been diagnosed and had access to treatment. But in 2012, Nigeria conducted a survey, a tuberculosis prevalence survey, where we found, amongst many other things, that men had more than twofold the burden of TB compared to women. But the TB program was not adequately reaching men. There was no guidance, no unified approach about how to get to the men in the communities and encourage them to seek care in a manner that aligns with their lives. The first thing we did was that we conducted an exploratory qualitative research to find out from the men what the challenges are. And they gave us a lot of points about how the health system is not structured around their needs. In our peri-urban communities, a lot of men depend on daily wage of informal work. There's a struggle to win bread for their families. And they tend to deprioritize an ordinary cough, which is the main symptom of TB. After hearing all the challenges men face, including lack of access to information about TB, the local TB Action Group is a group of influential men and women in the communities. They were responsible for implementing this intervention in the communities. They included palace secretaries, market leaders, the chairman of the Keke Napep Tricycle Operators Association, influential religious leaders, imams and pastors from the churches and mosques, as well as market women leaders, and also healthcare workers from the 2 healthcare centers in our implementation area. They were trained on the basics of tuberculosis, but particularly empowered to manage their budgets, develop their work plans, and map their communities and how they were going to spread the message of TB and coordinate screening for men in informal spaces. So for 6 months, they implemented this activity in Masaka area and Wuke communities. After the 6-month period of implementation, we then went in as the research team to do an end-line survey in order to compare it to the baseline survey we had already conducted prior to the intervention. And what we found was astounding. First, TB knowledge around TB, its causation, its services, where it's located, astronomically increased in the communities. The proportion of community members with the correct knowledge of the causation, transmission mechanism of tuberculosis dramatically increased, and stigma and discrimination towards TB reduced. One of the lessons we are learning is that to make sustainable progress in any health intervention, we must prioritize honest and transparent community engagement.
The LIGHT Consortium is a collaborative initiative that works to improve tuberculosis diagnosis, care, and services in high-burden areas, including Nigeria. It has a strong gendered focus on men. One of the most powerful aspects of the consortium's work is how it places the communities at the center of the conversation. Not just as beneficiaries, but as active members and participants who can tell their stories in addressing tuberculosis. I'll begin with the PEA, the Political Economy Analysis that was conducted by LIGHT Consortium. It was done to better understand the broader system within which TB programs operate. Our analysis examined how political priorities, governance structures, and funding flows and stakeholder interest influence TB policy and service delivery. For example, it helped us to identify why certain diagnostic tools may not be scaled up despite proven effectiveness, or how competing health priorities affect resource allocation for TB. By mapping out these power dynamics and institutional incentives, the consortium was able to design more realistic and implementable research. We also got good recommendations and design interventions that aligned with national priorities. The decision-making processes were informed by this process. The projects that we undertook include the Photo Voice project. And just a little bit background on the Photo Voice project. It is a participatory research method that empowers communities to use photographs to tell personal narratives and to document their lived experiences. In the LIGHT Consortium, what we did was to identify individuals who are affected by tuberculosis, including patients, caregivers, community health workers, and others. They were given simple point-and-shoot type cameras to capture images that reflect the realities of TB in their daily lives. These images taken were not just pictures, they were powerful stories of the stigma they faced in the community, the resilience and barriers to care that they faced. For example, some participants took photographs of long distance that they had to go to access care. Others took pictures of crowded environments that increased the risk of transmission of tuberculosis. Others captured the facilities that helped them adhere to treatment and supported them through their process. So these visual stories humanize tuberculosis beyond statistics, and it makes the disease more relatable to policymakers, to clinicians, and to the public. Our Photo Voice bridges the gap between data and lived experiences, ensuring that policies are grounded in real-world realities. Very closely linked to Photo Voice is the consortium's strong emphasis on community engagement. Effective TB control cannot happen without the trust and participation of the communities that we have engaged. The LIGHT Consortium worked directly with community leaders, patient groups, local health workers, civil society organizations to co-design and co-create interventions. Rather than imposing solutions, the approach is to listen first, to understand the community, their beliefs about tuberculosis, to address the myths and misconceptions, and to jointly develop context-appropriate responses through community dialogues, outreach sessions, local advocacy forums, and the consortium helped increase awareness about early testing, treatment adherence, and the importance of reducing stigma. One of the things we have realized is that when communities feel heard and respected, they are more willing to seek care early, to support those on treatment, and to champion TB prevention within their own networks. Evidence shared through parliamentary platforms contributes to the stronger advocacy for improved budgetary support, the integration of TB services into primary health care, and also scaling up community-based interventions.
A da ina ɗauke da cutar tarin fuka, da yardan Allah na sha magani kuma na warke. A dalilin wannan tarin har na samu ci gaba, aka sa ni a cikin wani program da ake ce mishi wani Photo Voice. Shi wannan Photo Voice ɗin a dalilin wannan Photo Voice ɗin an ba mu kyamarori mun shiga ƙauyuka da dama mun je mun wayar da kai. A da mutane ba su san meye ma'anar tarin fukan ba. Ana ganin kamar cuta ne wanda take kashe mutum. Amma ta dalilin wannan program ɗin nan da ake ce mishi Photo Voice ɗin nan, ai mun je mun wayar da kai da dama. Mun gaya musu menene ita wannan cutan, ya ne ake shan magani kuma a ina ne ake shan magani.
My name is Zainab Ibrahim. I'm a family member of a TB survivor. So because of this Photo Voice study,
I was able to educate people in the community that TB drugs is free. This picture in my hand was part of the photo voice, was part of the picture we took during the photo voice study. Because of this photo voice, I was able to tell people that TB is not a death sentence.
I'm the director of Zankli Research Centre in Bingham University, and also a professor, associate professor of infectious disease epidemiology and public health in Bingham University. I am the lead for the LIGHT Consortium, and the LIGHT Consortium we started in 2000. Throughout the life of the LIGHT Consortium, from 2000 to now, we were able to engage with stakeholders, which we started from the beginning. From the beginning, when we were even writing the grants, we reached out to the National TB and Leprosy Control Program, which is the body that is designated to supervise and oversee TB program in the country. And throughout the life of the project, throughout the life of LIGHT Consortium, each year we engage with the major stakeholders, not only the TB and leprosy control program, but other stakeholders like KNC, the IHBN, and others in country to work towards, pushing the issue of gender in TB. So, one thing we pushed in the LIGHT Consortium is to ensure that no one is left behind, especially disproportionality in terms of the TB burden among men, which affects women and children. So we pushed that in the LIGHT Consortium, and we did that by collaborating with other stakeholders in the country and even outside the country. We were able to introduce a lot of capacity building. We help also to ensure that other players or other people involved in TB in Nigeria are also aware of the issues. We even co-create some, these interventions that we co-create with almost major stakeholders at the top and even at the bottom. Community-led evidence were generated through the LIGHT Consortium. And one of the cardinal things that we did also at the level of the national is to ensure that we reactivate the operational research unit of the TB and leprosy control program, which we funded because it was dormant for quite a number of years.
I want to say a couple of things that LIGHT has done for us, working together with the LIGHT Consortium. The LIGHT Consortium was just more like a partner that came in about 6 years ago. It wowed all of us in the program because, first of all, was the fact that there was in-depth hands-on training for our Operation Research Task Team, which is made up of people from the program, our partners, other stakeholders, and academia. So we all joined hands and they taught us evidence-informed decision-making, which helped us to use the local data we generate to make informed decisions. And within that, also look into policies, some policies that they need to come in. Their work generally in gender was a game changer because they made us to see that even though we're getting a whole lot of numbers from males, identifying more males as with TB, but still when we look at it into the proportion and cascading it down or matching it to the incidence, that we were actually getting less males. So it was something that also made us to start looking into how to change implementation. Because now it gave us that insight that men are not within the community when the community healthcare workers are screening. They are at work, at the farm, at their business areas. So the conclusion, how do we take this screening, these interventions where men are? And that is also what has brought up the things we do in terms of portable digital X-ray, being mobile and move to place, having portable machines that can move from place to place. So by that, somehow, we'll be able to locate where men are. So now we've also aware how we kind of now disaggregate our data, not just looking at male, female. We look at the proportion, the contribution, how we have matched to the incidence. We also look at other things, the cascade, how many of them were screened, how many did we reach, how many dropped off, how many got to the testing platform. I want to add the fact of manuscript development. LIGHT was able to bring together all our state monitoring and evaluation officers to teach them how to use their data, to draft abstracts, to draft manuscripts. That singular intervention that year led us, for the first time, our state MIEs had to develop abstract and submitted to the International Union Conference, which is a bigger landscape for TB, a bigger TB conference. And within that, out of all those, about 11 of them that applied or submitted, we had 9. That is high acceptance rate. This was for the first time applying and sending in abstract for the first time, and we have 9 out of 11 accepted. That was a big feat. And within that, I don't want to mention local conferences because we now have high turnover of these data MIEs submitting for local conference, coming up with abstracts accepted, and also going in to present. So it's amazing the fact that within a short while, LIGHT Consortium had made impression that some partners who stay a long time mixing the program. Thank you, LIGHT, and keep the lights.
The fight against tuberculosis is not won by evidence alone, but by how the evidence is understood, how it is shared, and acted upon. Through the LIGHT Consortium, research has moved beyond reports and into communities, policies, and practice, shaping gender-responsive solutions, strengthening national systems, and ensuring that no one is left behind. As Nigeria advances towards ending tuberculosis, the legacy of the LIGHT Consortium endures. Evidence that informs action, partnerships that drive change, and communities placed at the heart of a more equitable TB response.